Okay, so let's get started. We're very pleased to have with us today Dr. David Burdette from St. John Providence Health System. He's an epileptologist with their Comprehensive Epilepsy Center and also works with Michigan Neurology Institute. Dr. Burdette, and the topic today, should probably mention that, is epilepsy, understanding and managing risks. So thanks everyone for joining us. And Dr. Burdette, can you introduce yourself and tell us a little bit about your background, your clinical and research interests, and also your experience working with patients with epilepsy?
Absolutely. And I thank everyone for joining and look forward to an interesting discussion. And Russ, thanks for having me. So with regard to my background, I did my epilepsy training at the University of Michigan in the early 90s. Then after a brief stint with the Air Force, I was at Henry Ford Hospital from 1995 through January of this year. And I'm now with as Russ said, the Providence St. John Health System, where I have the pleasure of working with two other epileptologists, Dr. Patricia Strimple and Dr. Amer Aboulkasem. With regard to my specific areas of interest in research in epilepsy, I would put them into three broad categories. One being the treatment of epilepsy. Secondly, the analysis of epileptic seizures. And then thirdly, what you might call the accompaniments of epilepsy. So I'll just briefly tell you what my interests are in each of those three areas. So with regard to the treatment of epilepsy, I have been involved in the evaluation of a number of anti-epileptic medications before they came to market, and my particular area has been to define the use of those drugs for different types of epilepsy. And I also have ongoing research projects looking at Statusepilepticus, which is a disorder that we'll probably discuss in a little bit.
Right.
With regard to the analysis of epilepsy, what I mean by that is to define what type of seizure someone is having so that we can guide treatment accordingly and potentially evaluate them for epilepsy surgery. And my specific area of interest is with high-frequency EEGs, looking at really super fast activity on the EEG that with older technology we couldn't see. So finally, with regard to the accompaniments of seizures, that would be those things that are the result of seizures. I have an interest in memory function as it relates to a part of the brain called the hippocampus, and I'll get into that in a little bit. As far as my experience working with patients with epilepsy, I am involved with predominantly patients who have difficult to control seizures. So I evaluate those individuals to define better what type of seizures they have so that we can tailor their treatment accordingly. I will evaluate patients for epilepsy surgery. I myself do not do the epilepsy surgery, but I evaluate patients for surgery to see perhaps if their seizures are coming from one part of the brain, and if they are, to see if that part of the brain is expendable. So if they had epilepsy surgery, they would be the same person walking out the door that walked in the door. And finally, in patients who may not be candidates for epilepsy surgery or may have had epilepsy surgery and it wasn't helpful, then I will look at other treatment modalities like the vagus nerve stimulator, perhaps aggressive doses of medications that we typically don't use in such aggressive doses. But those are my areas of interest, and that is generally what I do in the treatment of epilepsy.
Okay, great. Dr. Burdette, a key role for most physicians is assessing risks in patients and then communicating those risks clearly to patients and then working with the patients to make treatment and management decisions based on those risks. So before we talk specifically about epilepsy, can you talk a little more generally about the concept of risk and how that is used by physicians and patients?
Absolutely. Risk. As we know, it's kind of a general term that we use every day. And the way I conceptualize of that term is risk is, in essence, the chance of badness, the chance of something bad happening. And that badness usually takes the form of some sort of loss or some sort of injury. And of course, we can't live a risk-free life. If anyone figures out how to live a risk-free life, let me know, because I would be interested. But alas, I don't think it's possible. But as physicians and as patients, if we make smart choices, then we can minimize those risks. So with regard, Russ, to your noting that physicians need to communicate the risks associated with epilepsy clearly with patients, I would agree with that. That this is in many ways, I think, a dynamic interaction between the physician and the patient, that as physicians we need to have to promote a level of confidence such that our patients feel comfortable approaching us about questions about seizure-related risks, and that we are able proactively to address seizure-related risks with patients and their loved ones in order to minimize their epilepsy-associated risks.
Great. So you mentioned risks associated with seizures, and of course we'll talk more about that later. But I wanted to start out by touching on some other conditions that people with epilepsy are more likely to experience in the general population. So let's start by talking about depression. Can you talk a little bit about why people with epilepsy are at increased risk for depression, and then how likely it is that they will develop depression, and then what the various risk factors are, and what, if anything, people can do to reduce their risk of depression?
With regard to depression, we do know that depression in any setting, including epilepsy, is going to be multifactorial. There are going to be multiple causes, multiple factors that come into play with regard to depression. We do know, we actually have numbers from studies that looked at folks who had medically refractory epilepsy. So despite reasonable trials of reasonable antiseizure medications, they've continued to have seizures. And we know in those individuals that 25 to 55% of those folks have depression. If a patient's seizures are fully controlled, then the risk is lower. But to me, that's a pretty impressive number. Upwards of 55% of patients who have ongoing seizures will have issues with depression. Generally speaking, I look at depression in one of two ways. I will talk about what you might call reactive depression. And to me, a reactive depression is depression at a loss of function. So I am depressed because I have seizures and therefore can't drive. Or I am depressed because I keep having these seizures and I lose consciousness without warning. So I would consider that a reactive depression. I am depressed because I'm having seizures. But I would also differentiate what I would call endogenous depression. And endogenous depression is almost a chemical issue within the brain. It is a change in the neurochemical environment of the brain that actually produces depression. So if I can, I'll just tell you a brief anecdote. And this person is no one that any of you would know. This is someone I treated many, many years ago. And this individual's husband had been, I'm trying to scrub this as I go so that this person is completely unidentifiable, but this is an individual whose husband had retired and moved to a different job. And this husband's previous job was out in Nevada. And about a year before this person moved from Nevada to Ohio, she had started to have these odd episodes. And with these odd episodes, she would suddenly get this funny feeling of this sense of familiarity with her surroundings, this deja vu sort of episode. And invariably, it would be associated with this smell that was the same every time, so I would call it a stereotype smell of burned coffee. And these episodes were occurring fairly frequently, but she didn't think that much about them. She was still able to function. But around the time that these spells began, she developed depression. And back in those days, we used the Diagnostic and Statistical Manual version 3R, so the DSM-3R. And if you were to look up the criteria for depression in the DSM-3R, she met every one of those criteria. Loss of interest in activities that previously interested her. She felt sad. She felt like she wanted to weep. She had loss of appetite. Some people may have increased appetite, but she had many of these factors that are associated with depression, and she was in fact diagnosed with depression, major depression with psychotic features. The psychotic feature being this smell, this olfactory hallucination of burned coffee. So she was started on an old-timey antidepressant medication, and the depression improved, but she was still mildly depressed. And, the spells actually ever so slightly improved when she was started on this medication. So she was treated for about a year and then eventually moved with her family to the Ohio area, where she saw a very insightful primary care provider who heard her history of these spells and said, those sound like temporal lobe seizures, and ended up referring her to me. And to make a long story short, and it already may be a little bit too long here, she had right temporal lobe epilepsy. So I started her on a medication. Within days of starting the medication, these spells stopped. And within another few days of the spells stopping, all of her depression symptoms resolved, and she discontinued on her own her anti-epileptic medication. And as long as she remained seizure-free, she was depression-free. So here is a woman who had no idea that she had seizures. She, in fact, drove across country in a U-Haul truck having these seizures on a daily basis, was able, fortunately, not to get into a wreck. So she had no limitations on her activity. She had no reason to have a reactive depression. This was clearly an endogenous depression. The seizures were promoting a chemical change in her brain that was causing her depression. So that, to me, is a key dichotomy, if you will. Two types of depression. Reactive depression, we are bummed out. We are depressed about the fact that we're having seizures and the way that those seizures are affecting our lives. And endogenous depression, where seizures are actually causing a chemical change in the brain.
Right.
So, how do we deal with that? So, how do we deal with that? Well, our best way of fighting that is, of course, to treat the seizures. So if we treat the seizures, we can, and we're successful in doing so, then we can decrease the reactive depression, and we can also treat the endogenous depression. If, however, someone continues to have seizures, and there may be stressors in the person's life that are increasing their amount of depression unrelated to seizures. So what else can we do? Well, medications, as we know, particularly medications that I would call downers, that work by decreasing brain function, may increase depression. So you would want to talk to your physician about the possibility that the anti-seizure medications, the anti-epileptic medications, are exacerbating or making worse the depression. And then finally, I frequently extol the virtues of exercise. Exercise has its own beneficial effects on mood. And, of course, with exercise, we need to weigh the risks and benefits of exercise and the risk of seizures. And that's something we can get into in a little bit. But exercise can have a very beneficial effect and reduce the risk of depression.
Great. Are there certain types of epilepsy that are more associated with depression? Obviously, intractable epilepsy, but are there certain types like temporal lobe epilepsy or other types of epilepsy that are more associated with depression than others?
There is not a lot of good data out there from studies to address that question, but generally speaking, in my experience, I think that temporal lobe epilepsy likely has the highest association. Okay. One other point to make is if someone has depression despite control of their seizures or with ongoing seizures, and we feel that there is an element of this endogenous depression, this change in the chemical environment of the brain causing or contributing to the depression, then we will often treat with antidepressants. Antidepressant medications, when you look them up, to my knowledge, every one of them is associated with an increased risk of seizures. So again, we have to weigh the risks. Now, some antidepressant medications have more seizure-associated risk, and some have less. An example would be, and I'm blanking on the name of it right now off the top of my head. Thank you very much. Yes. Wellbutrin, even in someone who doesn't have seizures, if they are on 600 milligrams of Wellbutrin a day, they are at risk of having seizures. So you can imagine that Wellbutrin, although it is a very effective antidepressant medication, is probably not the one that you want to be on if you have a history of seizures. Most of our other antidepressants, though, carry an increased risk of seizures if they are taken to excess. So most of that risk is from overdose studies. People who have overdosed on antidepressant medications have an increased risk of seizures and may actually have seizures, whether or not they have epilepsy. So as we weigh those risks, we will typically choose an antidepressant medication that has a low risk of increasing seizures and then dose it non-aggressively.
Okay. Let's talk a little bit about cognitive difficulties such as memory problems or slowed processing speed or attention problems. These are common among people with epilepsy, and in some cases, these difficulties may be apparent before epilepsy is even diagnosed. In other cases, there may be more of a cognitive decline after a diagnosis is received. So how common is it for people with epilepsy to have cognitive difficulties, and what factors are involved, and then what can people do to reduce the risk of cognitive decline?
With regard to, I'm going to take this from the perspective of what causes the cognitive difficulties and then give you some speculation as to how often it happens.
Okay.
Because how often it happens is going to be a matter of degree.
Right.
So oftentimes when we think of cognitive difficulties, we concentrate on memory problems. At least in my clinic, memory problems are one of the foremost complaints. And in my experience, many of my patients, although I am oftentimes seeing patients who have had difficult to treat seizures, at least in the past, many of them will have some degree of memory complaint. Memory comes from two things, because, Russ, you mentioned attention problems. Mm-hmm. And attention problems are basically, as we all know, difficulty attending to or paying attention to what's going on around us. So, for instance, let's say I get home from work, I've got a lot on my mind, I hustle through the door, I yell for my son to get ready to head off to practice, throw my keys on the counter, change my clothes. As I'm getting ready to leave, I'm like, what the heck did I do with my keys? I was distracted. I was not paying attention to every little thing that I did. So when I threw my keys on the counter, I did not form a memory of it because I wasn't paying attention to that act. So when we form a memory of something, we have to be attending to it. We have to be able to pay attention to it. And we don't form a memory of everything that we're doing. Otherwise, it would drive us batty. So we pay attention to those things that we view as important. If, however, we have issues, for instance, with attention deficit disorder, or perhaps we have an issue with our parietal lobes or frontal lobes that do not allow us to pay attention as well as we should. Or if we're having frequent seizures, we're not going to be able to pay attention to what is going on around us. And finally, if we are on medications that suppress our cognitive functioning, we're going to have problems attending to things. So that, in many patients with epilepsy, is an issue. And I would differentiate that from a memory problem. So that person does appear to themselves to have memory problems, but it could be something as simple as they've got a lot of chestnuts in the fire there. They've got a lot of things on their mind, and they're distracted. So maybe they need some guidance about how they can be less distracted and pay better attention. Maybe they have ADD that needs to be treated, and that, of course, will be a double-edged sword because one of our most of our treatments of attention deficit disorder are stimulants. Stimulants can lower seizure thresholds. So again, as physicians, we need to weigh those risks and benefits, and we need to, once again, control seizures. It always comes back to controlling seizures. And finally, to treating the patient with medications that are going to minimize that risk of attentional problems. But once we've maximized attention, we still have to form a memory. And in our temporal lobes, if you put your finger just above your ear and point it straight in, that is where your temporal lobe is sitting. And way toward the middle of the brain is a part of the brain called the hippocampus, which is an area of particular interest to me because that's what I did my research in. And as you know, our brain is divided. We've got a left hemisphere and a right hemisphere. So we've got a left hippocampus and a right hippocampus. For most of us, we talk with the left side of our brain. So we say that our left hemisphere, the left part of our brain, is our verbal part of the brain. And so it makes sense that the hippocampus, that memory-forming part of the brain on the left, is what has to be intact for us to remember words, names, phone numbers, verbal information like this. Our right hemisphere sees more of the big picture and is sort of the creative part of our brain in many ways and is necessary for faces, remembering places, remembering how to get from point A to point B. And we call that nonverbal memory. So if someone has left temporal lobe epilepsy, it's not uncommon that they're going to have what we call hippocampal sclerosis. That is the most common finding on MRI scan in people with epilepsy. This hippocampal sclerosis. Sclerosis is a technical medical term for scar tissue. So left hippocampal sclerosis would be scar tissue within the left hippocampus. Right hippocampal sclerosis would be scar tissue within the right hippocampus. And as you can imagine, if you have scar tissue in your left hippocampus, that hippocampus is not going to function optimally. So you're going to have a problem with words, names, and memory for verbal information. And similarly, if one has scar tissue in their right hippocampus, they're going to have forgetfulness for places, faces, things like this. With that, once there's scar tissue there, there's not a lot that we can do about it, but we can try to prevent that scar tissue from forming. And there's good data that if someone has too many seizures, and those seizures involve either the left hippocampus or the right hippocampus, then they can get permanent memory problems. So once again, it comes down to control of seizures. Then finally, it used to be thought that however many neurons or nerve cells we have in the brain after we're born is pretty much as many as we're going to have. More recent research has shown, though, that we have these things called progenitor cells that are in a part of the brain called the ventricle that is, lo and behold, right next to the hippocampus, the memory-forming part of the brain. And it has also been shown that those progenitor cells will replenish the nerve supply within the hippocampus. So if somehow we could accentuate the ability of those progenitor cells to go into the hippocampus, then we might be able to improve memory. And there is research done in animal models, and this has been supported by research done in people, that low-grade exercise, so we're not talking heavy-duty weightlifting, which would not be a good idea in someone having ongoing seizures, but low-grade exercise, walking for at least 20 to 30 minutes multiple times a week. Some sort of regular low-grade exercise in all of us, whether or not we have epilepsy, will promote memory formation, maintenance of memory, and we believe the reason is because we're promoting those progenitor cells to repopulate the hippocampus.
That's fascinating.
I've
heard about that before, and one of my questions was, do those cells know where to go? Because sometimes if you have these cells being created, if they don't go to the right place, then that can cause more problems. But have studies shown that they migrate to the right place?
Generally, and this is still an early area of research, but all indications are that as we use neurons in the brain, the more neurons that are used, through factors that we don't fully understand, they will attract these progenitor cells.
Oh, okay.
So that it is believed that if we have an individual who is having memory issues, whether it be from seizures or not, that exercise will rev up these progenitor cells so that they'll be more likely to go where they are being asked to go. But in order to ask them, in essence, to go to the memory-forming part of the brain, we need to be doing tasks that require memory. There was a study done in older individuals who were at risk for Alzheimer's disease, and they found that individuals who exercised on a regular basis, but also individuals who were asked to write their memoirs, which is kind of an interesting aspect, because if you have to write your memoirs of when you were a memoir of when you were younger, you have to rely on your memory, and you're really exercising the memory-forming part of the brain. So I am a believer that the brain is an organ that does need to be exercised. So if someone is having issues with words, with verbal information, then they would want to do something that exercises that part of their brain. And a simple way to do that would be word find puzzles. And if those over time became too simple, then the person could graduate to crossword puzzles. Start simple and go, and then go to more complex puzzles. But these sort of things will exercise that left hippocampus. And similarly, the right hippocampus, there's a game out there called SET, S-E-T, that it's a nonverbal game, and it really exercises the heck out of the right hemisphere and really works that right, or should in theory work that right hippocampus. And as a disclaimer, I have no interest in the game SET, but it's just an example of a nonverbal game that if someone is having nonverbal memory problems, then it would be a way, coupled with exercise, that they could try to route those progenitor cells so that they populated their right hippocampus.
Right. Okay, so Dr. Burdette, briefly, can we talk about some of the short-term and long-term risks associated with anti-seizure medications, and then how you help patients to manage those risks? Obviously, there's a lot of risks associated with specific medications, and we don't necessarily need to get into those, but what are some of the key ones that you look out for when you're prescribing medications?
I would say an early risk, an early adverse effect would be, of course, what we globally call a hypersensitivity reaction. That if a medication either promotes an antibody response by that person, or if it causes the body to attack itself type thing, then you can have what we call a hypersensitivity reaction. The most common of those would be a rash. And generally, rashes or hypersensitivity reactions are going to occur within the first 3 to 6 months of a person starting a given medication. And I won't go into specifics, but certain medications are more hyperallergenic, if you will, than others. Regardless, any medication, though, can cause a rash or a hypersensitivity reaction. If we know that we're starting a patient on a medication that has a higher than average risk of a hypersensitivity reaction, then we may, after the patient has been on it for a brief while, check a laboratory evaluation and make sure that their liver is doing okay, make sure that their blood counts are doing okay. So that is something that we will pay attention to, particularly for the first 6 months that someone is on a medication, although frankly the risk goes down significantly after 3 months. Some medications, however, can, after a person has been on it for a long period of time, produce a rash or hypersensitivity reaction. It is quite rare for that to happen, but it can. So if a patient suddenly notes that they're having issues with rash, or they just are not feeling right, they're feeling dragged out, having flu-like symptoms when they don't have the flu, and this sort of thing, they should contact their physician, and we can check a laboratory evaluation and see if there's any evidence of a hypersensitivity reaction. Other short and long-term risks might include weight gain. Some of our medications are more prone to weight gain than others. Some may actually promote weight loss. But as sure as I'm sitting here, This is a very individual phenomenon. So I may start a patient on a medication that generally promotes weight gain, and lo and behold, in that person promotes weight loss, or vice versa. So these tend to be very individual responses, but most of your physicians will be well aware of those medications that are commonly associated with weight gain and those that are commonly associated with weight loss. Now, in our ever-growing population, and I know all too well that I'm watching my weight growing in that sense all the time, many people find that weight gain is going to be more of an issue than weight loss. And weight gain, as we know, can have a number of secondary effects in women and in men, actually. Adipose cells, the fat cells, if you will, have enzymes in them that generate estrogens. So the more adipose tissue we have, the higher our estrogen levels are, whether we are male or female. And if that estrogen is too high in women, then it can promote polycystic ovary syndrome. And additionally, if someone gains weight, then they will be at risk for metabolic syndrome, which includes polycystic ovaries. It also includes insulin resistance. And if someone gets to that point, they definitely need to see an endocrinologist to try to mitigate those symptoms. Ideally, we will be able to find a medication in a patient that will not produce weight gain. But every now and then, we'll be between the proverbial rock and a hard place where a person's seizures are only controlled with a medication that also promotes weight gain in them. And then we will try to work hand in hand with an endocrinologist in order to minimize that effect. Another short and long-term risk would include pregnancy risks. Generally speaking, in women with epilepsy, there is a background risk of about 2% of birth defects in their children. We have, the FDA will designate pregnancy categories for various anti-epilepsy drugs. The vast majority of medications are Class C, indicating that they carry a theoretical increased risk, and basically it's indicating this theoretical and fairly well-defined increased risk. Some of our medications are Class D, and again, I won't get into specifics, but Class D medications would be ones that we would clearly want to avoid because they have a strong association with birth defects. The most common birth defects that have been associated with anti-epileptic medications are spina bifida, and spina bifida is not well, I guess there are no good birth defects, but it is a particularly tough one. Other ones include cleft lip, cleft palate, various urogenital issues, and potentially cardiac issues. But the big ones that we are concerned most commonly with are the risk of spina bifida and the risk of cleft lip and cleft palate. One way that we can reduce those risks, specifically spina bifida, in any woman, including women with epilepsy, is to have her taking folic acid pre-conception. And the recommendation for folic acid is that all women should be on 0.4 milligrams, also known as 400 folic acid per day pre-conception, and that women who have had a previous pregnancy complicated by spina bifida should be on at least 4 milligrams a day, and that other groups, and included amongst those other groups are women with epilepsy, should be on somewhere between 400 micrograms and 4 milligrams a day. So that's the folic acid story. A couple of other things, bone loss. We know that there is an association between long-term antiepileptic drug use and bone health issues. We also know that antiepileptic medications that are what we call hepatic enzyme inducers, which in English means that they rev up the liver to eat up other substances faster, will promote low vitamin D levels, which can also promote bone health issues. So if a person is on an enzyme-inducing medication, they would want to have a 25-hydroxy vitamin D level checked to see if they need to be on a vitamin D supplement. Also, as an aside with vitamin D, we know that sunlight exposure increases vitamin D levels, also increases risk of skin cancer. But in Michigan, we don't worry as much about high levels of sun exposure because we don't have as high levels as they do where Karen is down in Texas right now. So the vitamin D levels are something that is a simple blood test that we can help assess your bone loss risk. But there are other factors with regard to medications that can cause bone loss, and your neurologist can discuss those with you and may want to check a bone density study or DEXA scan to serve as a baseline, and those can be repeated reliably every 2 years. Finally, all of us as we age, our bodies slow down a little bit, and our liver doesn't have quite the blood supply that it used to have, and so it doesn't break down medications, metabolize medications as quickly. Our kidneys don't function quite as well. So oftentimes when antiepileptic medications are started on those of us as we age, the medications will be started at a lower dose and the titration will be slower in order to minimize the effects of toxicity. And those are the only ones that I can think of off the top of my head, Russ.
Okay. So let's talk. When most people think of risks associated with epilepsy, the most obvious risks really are those related to seizures. So what are some of the most common injuries that you see in patients with epilepsy, and what, if anything, can be done to prevent some of these injuries?
Injuries, I'm going to talk about external injuries, if you will, and let's say internal injuries.
Okay.
So probably the most common injuries that I run into will be with generalized convulsions. It would be something on the order of oral trauma, so someone biting down on their tongue or the inside of their cheek, and that can be quite painful for a few weeks thereafter. We also have risks of broken bones from falls, and I think we're going to talk about some other seizure-related risks in a little bit. But so those are arguably the most common risks that I run into, are those that result from either tongue biting or perhaps a broken bone, something like that. In the past, it was not uncommon for me to see patients who would have a portion of their front tooth broken out when someone tried to jam a spoon into their mouth in order to keep them from, quote, swallowing their tongue. As we all know, and most people are aware of this now, that it is physiologically impossible to swallow your tongue, and that putting something in someone's mouth is not going to significantly reduce their risk of having bitten their tongue. So our best first aid options are to help the person to the ground if they're not already on the ground, and in order to minimize risk of head injury and this sort of thing, to remove objects from around the person to reduce risk of injury, and to roll them on their side because anyone who is having a seizure will tend to have sialorrhea, which is excessive production of saliva. And at the end of a seizure, particularly a convulsive seizure, a person will invariably give a deep breath. And if they are lying on their back and their mouth is full of all of this saliva, they may suck that saliva into their lungs and get what we call an aspiration pneumonia. So those would be sort of internal injuries, if you will. Externally, your physician will counsel you to be circumspect, to be smart in your choices of environment and your choices of activities. So, for instance, we have a driving restriction. We, in theory, a person with epilepsy should not operate power tools or power machinery that do not have adequate safety devices. A person with frequent seizures should probably not cook. I have seen a number of individuals who have such extensive scarring on their hands that they have limited movement of their fingers, and these resulted from them in the midst of a seizure placing their hand on a hot eye and the seizure suppressing the reflex to take it off. So avoiding those activities, avoiding swimming. With regard to the swimming, I occasionally get a fair amount of pushback. My rationale for that is that if someone has a generalized tonic-clonic seizure, a generalized convulsion, and they are underwater, they will override something that is called the diving reflex. When someone drowns, for minutes, a prolonged period of time after they have drowned, they will not have water in their lungs because this diving reflex closes off your glottis, keeping you from sucking water into your lungs. If you're having a generalized convulsion, you will override that. You can suck water into your lungs, and then that makes resuscitation very difficult. So should avoid swimming, should avoid bathing in more than 3 inches of water. Fortunately, this is uncommon, but most of us treating neurologists have known patients who drowned in a bathtub. One should avoid unprotected heights, and generally, as a rule of thumb, I will say avoid activities during which the occurrence of a seizure could result in significant bodily harm to the patient or to others.
Right. Are there different situations where you recommend helmets for people with epilepsy? A lot of people use them if they have drop seizures. Is there a reason why that's more common than people who have frequent generalized tonic-clonic seizures? Are the types of falls or the risk of brain injury from a fall different with different types of seizures? So I guess what circumstances would you recommend someone wear a helmet?
Yeah, as a general rule of thumb, I would counsel someone to wear a helmet if they are having frequent seizures during which and if they're having frequent seizures and during their seizures, they tend to fall in an unprotected fashion and strike their head. That having been said, many people are resistant to wearing helmets for cosmetic reasons. And and I find this particularly in some of the developmentally delayed population that their head gets hot and sweaty and it's uncomfortable to wear a helmet.
Right.
So it would be nice if we could live a risk-free life, and any of us could fall in an unprotected fashion. We could faint, have syncope, the technical term for fainting, and fall in an unprotected fashion and whack our head. Generally speaking, if you fall from less than your natural height up to your natural height and hit your head, it is unlikely that you're going to sustain a significant brain injury.
Okay.
If you fall from a greater height than that, the risk goes up exponentially. And it's clearly not good for you to fall from your full height onto your head, but the risk of having significant direct brain injury is not massive. Mm-hmm. The one caveat is that if you're doing that on a regular basis, you may get a cumulative problem. So to your observation about individuals with drop attacks are most commonly seen, as we all know, in a very difficult to treat form of epilepsy, a syndrome called Lennox-Gastaut syndrome. And those individuals will invariably have frequent seizures of multiple types, including drop attacks. And those drop attacks may take the form of tonic seizures, where they become rigid and fall like a tree and they smack their head, or they may have atonic seizures and fall like a sack of potatoes and boom, smack their head. In those individuals, because they happen so frequently, they should be wearing helmets. Similarly, if someone has generalized convulsions that are happening frequently and resulting in head injury, they too should wear helmets.
Okay. And back to the driving issue, are there circumstances under which, I mean, basically the law says if you've had any type of seizure in the last 6 months, you shouldn't be driving, but do you see any exceptions to that? For instance, if you have reliable auras, or if you only have nocturnal seizures, or any other circumstances where you would counsel a patient that it may be safe to drive, even though technically the regulation says any type of seizure?
So this is a very legally tinged area,
right.
For obvious reasons.
Yeah, of course.
And Michigan law does state if you have any type of seizure, or I believe any form of loss of consciousness, that would include fainting, you should not drive for 6 months. And yet, somehow, people who faint, unless they faint on a regular basis, are generally not counseled about seizure, or not counseled about driving. The one point in favor of fainting episodes is most people do not faint when they're sitting. Okay. They'll faint when they're standing. Mm-hmm. So that is how people kind of get around that aspect of the law. It's been a couple of years now, called the Secretary of State in Lansing, and I asked about this law because I had a couple of patients who were had not had a complex partial seizure or a secondarily generalized tonic-clonic seizure in a number of years, but on a rare basis would have the slightest hint of an aura. So subtle that we weren't even sure it was an aura. But nevertheless, thought that they were auras, which technically are simple partial seizures. What should I do? So I talked to this representative of the Secretary of State and asked, what should I do? And she said, is the person having seizures? I said, yes, simple partial seizures. She said, they can't drive. I said, well, these simple partial seizures in no way impact their ability to operate a motor vehicle. She said, well, then, they can drive. And I said, oh, can I get that in writing? No.
Right.
So we're between, the proverbial rock and a hard place. Generally speaking, and I'm not going to make any blanket statements, but generally speaking, in that situation, I make sure the person knows about the Michigan law, make sure that they know to tell me, were they to have another more severe seizure. But if they have had exclusively auras or simple partial seizures, then I will oftentimes not restrict their driving. similarly, if someone has the subtlest of myoclonic seizures, perhaps a person with juvenile myoclonic epilepsy, their absence seizures, well controlled. Their primary generalized tonic-clonic seizures or grand mal seizures, well controlled. But every now and then they'll have a little twitch. I will tell them on the morning, because most of those twitches occur within an hour of awakening in the morning. On the morning that you wake up having twitches, don't drive that day. But otherwise, be careful out there, avoid sleep deprivation, etc. With regard to the patient who says, every time I have a seizure, I have an aura and have time to get the car over, that, to me, doesn't quite cut it, because I've seen many a patient, and there's actually a literature to support this. There are studies to show that even folks who will get a reliable aura are not immune from getting a seizure without an aura. And similarly, people who have predominantly or almost exclusively nocturnal seizures, there's no rule that says they couldn't have a seizure during the day.
Right.
So in those cases, I will typically make the unpopular decision to recommend against driving. If a seizure occurred during illness, I guess it would depend what the illness was. But to me, illness is a physical stress, and if I cannot control someone's seizures adequately to get them through a physical distress without having a seizure, then they probably shouldn't be driving at that time. But the final caveat is epilepsy monitoring unit. If I bring someone into the epilepsy monitoring unit and in a physician-supervised setting, they were taken off medication, they had some seizures, we put them back on, then I will recommend that they wait a few weeks before returning to driving, but then they should be good to go.
Right, and that actually is written into the regulation if you have a seizure during a medically supervised change in medication or something like you mentioned. So, okay, great.
Can I ask a question?
Yeah, go ahead.
Yeah.
What do you recommend a person be able to fly on a plane?
I think they should be able to fly. I would generally speaking, I would base my recommendations on how often they're having seizures and how severe the seizures are. But generally, I am okay with the patient flying, and depending on their frequency of seizures, I may pre-medicate them with an oral dose of Ativan. But the act of flying, the changes in the barometric pressure generally will not have a significant adverse effect on seizure control. If, however, a person has a known issue with changes in barometric pressure, because seizures can have any number of triggers. Mm-hmm. So if for a given individual, this would be very rare, but if for that individual significant changes in barometric pressure trigger their seizures, I would advise against them flying. For most anyone else, I would say flying is fine, but I may want to pre-medicate you.
Okay.
Let's talk another seizure-related risk is status epilepticus, which is prolonged seizure activity, either one after the other or continuous seizure activity. That can lead to brain injury or even death. But first, can you talk a little bit about the different types of status epilepticus? You can have non-convulsive versus convulsive status epilepticus. You can also have status epilepticus caused by epilepsy versus status epilepticus caused by some other medical condition, and talk a little bit about the different risks or the relative risks from those different types. And then also talk about how common these are in different populations. And after that, if you can talk briefly about any rescue medications and that can be used in the non-clinical setting, and then how those might be used to reduce the risks of injury from status epilepticus.
Yeah, status epilepticus is a particular interest of mine. And status epilepticus, simply speaking, as we all know, is seizures out of control. And there are as many types of status epilepticus as there are types of seizures. So if someone has exclusively simple partial seizures, let's say you have seizures that involve focal jerking of one arm or one leg, you could go into focal status epilepticus, where it was either continuous jerking of that arm or leg or recurrent episodes of that. If someone has convulsions, they could have recurrent convulsions. If someone has absent seizures, what used to be called petit mal seizures, and they are put on a medication that can exacerbate absent seizures, then they could go into absent status epilepticus, continuous absent seizure activity. So any type of seizure, when happening in excess, could cause status epilepticus. We will roughly differentiate between convulsive and non-convulsive status. So convulsive status epilepticus, we usually think of convulsions, recurrent grand mal seizures, or recurrent generalized tonic-clonic seizures. And that, of course, is the worst of all epilepsy situations, because that is actually a potentially life-threatening situation until you can get those seizures under control. Non-convulsive status epilepticus could be recurrent simple partial seizures, could be recurrent or continuous absent seizures. Generally speaking, as you can imagine, the non-convulsive status epilepticus is going to take less of a toll on the body and the brain than convulsive status epilepticus. The most common cause of status epilepticus is epilepsy. It's individuals who have known epilepsy and maybe missed multiple doses of medication, or maybe they have an illness that has lowered their seizure threshold, or maybe, God forbid, they have used substances that have lowered their seizure threshold. But the most common forms of status epilepticus that we see will be in individuals who have known epilepsy. And the type of seizures they're having will typically be similar to the types that they would ordinarily have, only in this situation they're happening back to back to back or in one prolonged fashion. Other causes could be more acute causes. If someone has encephalitis, a brain infection, brain fever it's been called. So if someone has an infection that involves the brain, that could be a viral infection like herpes simplex encephalitis or eastern equine encephalitis, or it could be bacterial. It could be a bacterial infection of the brain. That could cause status epilepticus in someone who has never had epilepsy or an epileptic seizure before. And if we can control both the infection and the seizures, and that person lives to walk out of the hospital, there's a pretty high chance that they could have epilepsy again. So any badness of the brain, anything that causes a significant brain injury could cause status epilepticus. Now, there is another type of seizure that we will call acute symptomatic seizures, and these seizures are a manifestation of something else going on. So, for instance, if you have someone that is a big-time alcoholic, they drink on a regular basis in large quantities over a long period of time, and then they stop cold turkey, they can have a withdrawal seizure. And if their brain had gotten used to alcohol over a long enough period of time, they could actually go into status epilepticus. Typically, that will be convulsive status epilepticus. It'll be a tough situation. Another more benign example is what I call non-ketotic hyperglycemia. In patients with diabetes, it is not uncommon, fortunately not common, but it's not uncommon for individuals' blood sugar to go too high. And one of those situations where that happens is diabetic ketoacidosis, which is it's a medical emergency. But people in diabetic ketoacidosis have high ketones in their system, and ketones decrease risk, they suppress seizures. So people in diabetic ketoacidosis, although they are extremely ill, do not typically have seizures. If, however, you have someone that's type 2 diabetic whose blood sugar is running in the 400s, so they're not making ketones, they can go into focal status epilepticus. And I've seen people who had jerking of one arm that was going on for a long period of time, and I saw another person who had recurrent visual hallucinations that were due to simple partial seizures. And what we do in that instance is we treat the status epilepticus aggressively, but we treat the underlying cause. And then the person will be, once we get the seizures under control, they will be discharged to home on their new diabetic regimen, but also on at least one anti-seizure medication that we continue for 3 months and then take them off it. With regard to risks, the risk is going to be variable, but is going to be driven by how well people with epilepsy are doing taking their medications. And the more reliable we are in having a person take their medications, the lower their risk of status epilepticus. And status epilepticus, especially if it's convulsive, can cause permanent cell loss in that part of the brain we talked about earlier, the hippocampus, the memory-forming part of the brain. One final aspect of status epilepticus is the sooner we can treat it, the better the outcomes. So our basic initial line of treatment for every type of status epilepticus is benzodiazepines. That could be lorazepam, diazepam, midazolam. What benzodiazepines do is they will treat the acute seizures and buy us some time in which to get the person on a longer-acting medication and buy us some time to figure out exactly what's going on. So the sooner we can start that benzodiazepine, the better. So if a person is prone to status epilepticus, they would want to have a benzodiazepine available to them at home. And that could be a benzodiazepine that they could take orally. Although, frankly, oral benzodiazepines are not as good or as effective as other routes of administration. We have some that are rectally administered, and there are studies to show that that can be very helpful. And then there are some newer ones that may be administered via nasal spray.
Okay. So one of the last things I wanted to talk about was SUDEP, or sudden unexpected, or sometimes it's called sudden unexplained death in epilepsy. And that has recently become a major topic of discussion in the epilepsy community. It used to be something that physicians often didn't mention to patients, but as people learn more about it, and people who've lost loved ones due to SUDEP often asked, why wasn't I told about this? And I think that may have led to more discussion and more awareness of SUDEP. So can you talk a little bit about SUDEP and the suspected causes, some of the risk factors, and then potential ways to reduce your risk for SUDEP?
Yeah. So SUDEP, for years was known as sudden unexplained death in epilepsy. But about a decade ago, a consortium of specialists got together and decided we've got a pretty good idea of the top 2 or 3 causes of this phenomenon. So we changed it from unexplained to unexpected. So sudden unexpected death in epilepsy. And as the name implies, it is a straightforward term. It is the worst of all possible outcomes from a seizure. And sudden unexpected death in epilepsy occurs within an hour of a seizure. Fortunately, the risk is low. The risk is largely driven by frequency of seizures. So the more often someone has a seizure, the greater their risk. And not all seizures are equal. We know that the number one seizure type associated with SUDEP is the generalized tonic-clonic seizure, what we have over the years called a grand mal seizure. The more grand mal or generalized tonic-clonic seizure someone has, the greater their risk of this sudden, unexpected death. And that death will occur, we believe, by one of two pathways. Any one of us who has seen a grand mal, a generalized tonic-clonic seizure, know that during that first initial major phase of the convulsion, the person is just clamped down. They are rigid. Every muscle over which they have voluntary control contracts, and that includes their diaphragm. So they emit this ictal scream, and then they can't breathe because their diaphragm is contracted. And it's like running a 400-meter dash, carrying weights, and you can't breathe. So the heart is just bang, 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 beating to beat the band, and the person is not breathing. So the heart is circulating unoxygenated blood. As you can imagine, that is a major, major stress on the system. In fact, the brain and body can't sustain it. So initially, you get this brief relaxation, and then the convulsion is back. And then a relaxation and back, relaxation and back. And that person has now made that transition from the tonic phase of the seizure to the clonic phase, hence the name generalized tonic-clonic seizure. Those relaxations get bigger and bigger and bigger, and finally, boom, the person stops seizing. They are out cold. Their brain is almost flatlined, but not quite. And at that time, their brain is diffusely inhibited. And we know from our experiences in the epilepsy monitoring unit that a small, fortunately very small subset of people will not take another breath. They will have what we call primary respiratory failure. And that's why when you're in the epilepsy monitoring unit, people come running with a convulsion, and we make sure that that phenomenon does not occur. That phenomenon is most likely to occur if a person is flipped over onto their stomach, or if they're lying flat of their back and their tongue has relaxed back over their airway. So even though they haven't swallowed their tongue, it is harder for them to breathe. And so it is believed that this primary respiratory arrest is the predominant cause of SUDEP. Also accompanying that is with regard to timing of seizures. It is known that nocturnal seizures, seizures out of sleep at night, have a higher rate of SUDEP than those that occur when a person is up and about. It's also known, because there's such a stress on the heart, that people can go into abnormal heart rhythms after a seizure, and it's also believed that a subset of people, it'll be from a cardiac cause, either a heart attack or an abnormal heart rhythm. So cardiac causes and respiratory causes are the primary, believed to be the primary reasons that sudden unexpected death in epilepsy occurs. The key risk factors are if someone has an underlying lung process, so they have a baseline respiratory problem, a baseline heart issue, or if it's after a generalized convulsion or a seizure out of sleep. In different subpopulations, the incidence is going to be greatest in people who have generalized convulsions, and our best way to reduce that risk is to get rid of those generalized convulsions. And if we can't do that, then it can be difficult. I do have patients whose loved ones have set up a baby monitor type thing so they can hear when their loved one has a nocturnal convulsion. And so they can go in and check on them. But it can be very tough to prevent unless we can stop those generalized convulsions. As far as the overall incidence, we calculate that in patient years. So if someone has well-controlled seizures, we're dealing with an incidence of 1 in every 1 to 2,000 patient years. So to put that in English, if you follow 2,000 patients over the course of a year, there is a statistical likelihood that one of those 2,000 people who has well-controlled seizures could have SUDEP. If, however, you look at a population of people with uncontrolled, frequent, generalized tonic-clonic seizures, and those are also happening out of sleep, then the risk is 1 in 100 patient years. So if you follow 100 patients who have frequent generalized tonic-clonic seizures, particularly out of sleep, over the course of a year, the likelihood is one of them will have SUDEP.
I have a question.
Mm-hmm. Yes.
My question is, if a patient, I don't know, I guess if a patient has gone into status on more than one occasion, is there a risk higher for sudden unexplained or sudden unexpected death in epilepsy?
Their risk was this convulsive status like grand mal seizures?
Yeah, my son, he's 4, he has generalized convulsive epilepsy. That's his primary diagnosis.
Okay. I would say 2 things, and this is, unfortunately, it is a good news and a bad news thing. The bad side of things is that with convulsive seizures, the more you have, it puts you into that high-risk category. And as we had talked before with Statusepilepticus, that's the worst of all possible seizure-related situations. So I would say that convulsive status epilepticus does place him more toward that 1 in 100 patient year category. Now, the good news is that SUDEP is less likely to occur in young children. So you said he's 4, correct?
Yeah, he's 4, and we've been in status 7 times. He's had to be intubated twice.
Okay. I would say, I would make a couple of observations. He is, due to his age, not in the 1 in 100 patient year category. He's probably more like a 1 in 400 to 500 patient year category, which I know is hard to put into real life, but he is not, if he was 30 years old going and had gone into status epilepticus that many times, mm-hmm. It would be a very scary situation. Not that it isn't scary in a 4-year-old, but his age works in his favor because he's got healthy lungs and a healthy heart. What I would do, if he has tended to go into convulsive status out of sleep, is consider the baby monitor thing.
We actually have a baby monitor, a video camera, and like a pulse ox because he has felt breathing a couple times during the night.
Good. So it sounds to me like you're dealing with his very difficult situation in an ideal fashion. And in doing so, you're further reducing his risk of SUDEP.
Thank you very much.
You're welcome.
Okay. Other questions? I think it could be related.
Hello, Dr. Burdette.
Go ahead.
Yes. Yes.
This is Karen Gooding.
Yes.
I got a question. You've known me for so long. I was just told that taking Benadryl can bring on seizures.
Yeah, Benadryl falls into the same category as some of our older antidepressants. The Benadryl seizure data is based on people who took an overdose of Benadryl. So if someone takes an overdose of Benadryl, it'll cause seizures, whether or not you've ever had seizures. Because of that possibility, it is a warning on in the Benadryl package insert that Benadryl can cause seizures. In my experience, Benadryl does not tend to cause seizures unless you're on a very high dosage of it. And then it's and in lower doses, there will be people out there who are extraordinarily sensitive to Benadryl. But generally, most of my patients, I don't like them to take Benadryl, for instance, for allergies or for insomnia. I don't think it's a good fix personally. But Benadryl probably will not cause their seizures if it is taken in a low dose. It's analogous to caffeine. We know most people drink caffeine. There are actually studies to show that in the typical doses that we drink caffeine, that it does not affect most people's seizure thresholds. Some people are extraordinarily sensitive, but most people it doesn't. But we also know if we take one of those poor little laboratory animals and pump its belly full of pure caffeine, it'll have a seizure. So caffeine can cause seizures, but in the amounts that we take it in, it is unlikely to. And I would say the same thing with Benadryl. And I would say the same thing with most antidepressant drugs. They can cause seizures, but in the doses that we use them, they are unlikely to, as long as we're careful on our choices.
So you're saying it can bring on like my little 5 to 7 second ones that I have still? Like once a month?
I would think it is unlikely, but everyone is different. So if you were to notice that every time that you took Benadryl, you were more likely to have a small event, then I would say don't take Benadryl.
If I take it every day.
So that could be tough. So what you might do to test that hypothesis is to not take it for a week or two and see if there was a difference.
Okay.
Other questions?
Dr. Burdette.
Yes.
This is Kathy Ray. I seen you when you were at Henry Ford Hospital.
Yeah. Yeah.
Nice.
How are you doing?
Hello?
In depression since February. Can you hear me?
Yes, I can hear you.
Okay. I've been taking Keppra XR, and Vimpat, and clozapam at night. And all of February, I've been in depression, and my regular doctor told me to take clozapam in the middle of the day, and it would help. But most of I don't know if this should be brought up, but most of my depression is because of my insurance. And the issue and what makes me feel better is, I don't know why, maybe it's normal, but is when I can get things answered or find out things. And what I've been fighting for is trying to get it explained to others what epilepsy is, because I found out a lot of people don't know about epilepsy. And is it wrong to take the clozapam 2 times a day? Is that what would help me with my depression?
I would say, generally speaking, what you're describing is likely a mixture of, remember I talked about that reactive depression, and I would consider the concerns that you're having with regard to the stress related to your insurance and whatnot would be a form of reactive depression. And then anyone with seizures could have an element of an endogenous depression. So when you talk to your physician about the depression, what they will try to do is to tease out how much of this is reactive, how much of this is endogenous, and if there is an anxiety component to it. such as you might be anxious about your medical insurance situation. So if there is a significant element of anxiety, then a benzodiazepine like Klonopin or clonazepam can be very helpful. If, however, a person has no element of anxiety and it is pure endogenous depression, you probably would not want to use Klonopin because clonazepam is a downer. It kind of brings you down a little bit, which is good from the anxiety perspective or stress perspective, but it's not good from the straight depression perspective. So in that instance, you would look toward taking an antidepressant medication. So it all depends what the prescribing doc felt was going on, but I suspect since he or she started clonazepam that they felt that there was an element of anxiety. And with any drug like clonazepam, if you're getting some benefit from one a day, I would run it by the person who prescribed it and make sure they're okay with going up to twice a day. But if they are, then I think it would be very reasonable to go up to 2 times a day.
I have a question, or kind of more of a comment. I don't hear. I'm hearing a lot about depression. I didn't hear anything about maybe referring people to behavioral health services. I think
Go ahead.
I was going to say, I see that. I'm a health professional myself, and I just see people with chronic illnesses that tend to have, just based on the fact they have a chronic illness, have depression. And I just see a missing link a lot of times in that, where the referral should actually be made there and, some talk therapy and do you agree?
I do. Early on, I had a level of discomfort because of the theoretical risks of antidepressants exacerbating seizures. So I talked with a handful of my psychiatry colleagues, and their feeling was that if someone was having a fairly straightforward picture of depression, if you will, if there is such a thing, that it was very reasonable for me to get that person a trial of a reasonable antidepressant medication. And if that didn't help, then I should refer to a mental health, behavioral health professional, specifically a psychiatrist. Now, with regard to psychology, I'm not going to talk about neuropsychology, but just straight psychology. I think that psychological counseling is a useful adjunct to either the medical treatment of depression, or, as I believe you're pointing out, not every depressed patient has to be on an antidepressant medication. Maybe counseling is all they need, in which case I am a firm believer you want to be on the least amount of the fewest medications possible. So if counseling will get the job or will help, then absolutely. And I do try to offer that to my patients as well. So, and I did overlook that in talking about it, and I appreciate your pointing that out.
I have a question.
Go ahead.
Yeah.
Yeah, this is Peggy Karcher, and I have just a question we haven't really talked about, but I often wonder about it. If let's say an oral surgeon or a dentist or a family practitioner needs to cure my adult son who takes epilepsy medication and is going to use an anesthetic or an antibiotic, and I don't know, am I to worry that this, because he is not familiar, say, with the interaction between epilepsy medication and the anesthesia and antibiotic, what should he do or what should we do as a family to get through that?
I would recommend that the person who is going to be doing the procedure or prescribing an antibiotic or both contact the neurologist or epileptologist, because as we both know, many of our anti-epileptic medications have interactions with antibiotics, and certain antibiotics are more seizure-prone than others, such as ciprofloxacin is well known to lower seizure threshold, and that's not the only one. I don't mean to hate on ciprofloxacin, but just to throw it out there as an example. And we know that there are many, as I said, potential interactions. And additionally, with regard to anesthesia, most anesthetics are going to be okay because they're going to decrease brain function, and therefore they're going to decrease risk of seizures. But when I am asked, I will typically clear someone for their surgical procedure, but I will recommend that amongst their anesthetic agents that they receive either a barbiturate or a benzodiazepine, something that we know makes a person less likely to have a seizure.
Okay, when you said contacted Dr. Neurologist, what if this is, okay, if you can wait, if it's something that can wait, if it's like say an oral, surgeon, wait a few days or wait for a while, it's easy to contact, but what if it's like an emergency or a urine infection that has to be treated right away? Ciprofloxacins, I think, are the only thing that cures some kind of urine infection.
They're going to have other options, I would say, but if someone has to take Cipro, they've got to take Cipro. And not every person that takes Cipro is going to have a seizure. I would say specifically with regard to ciprofloxacin that the person cut out all caffeine use, because Cipro will double the caffeine half-life, and you can build up caffeine levels to a dangerous level with it, which will affect seizures. So generally, we can work around these things, and if there's an emergency situation where someone has to have a procedure, the vast majority of anesthetics are going to make you less likely to have a seizure. In fact, hardcore, big-time status epilepticus, if we can't control it with regular medications, we start with the anesthetics to shut the brain down.
That's interesting. Okay. As you said, if you have to have it in an emergency, you have to have it, right?
Exactly. And then we can work around that.
Okay.
First.
Russ?
Yes, go ahead.
This is Greg Schultz. And the doctor said that anybody that has a seizure disorder, they shouldn't cook, right?
It depends on the type of seizure. But if someone has seizures where they blank out and they could either fall into an eye that is on or an open flame, or they could involuntarily place their hand or other body part on that, I would not cook. But if a person's seizures are simple partial seizures and they would be able to move themselves away from the stove without pulling something boiling onto them or whatever, then it would be okay. So you would have to weigh that risk and benefit.
And of course, there are other options too, like using a microwave to cook might be safer, cooking on back burners rather than the front burners. So again, it's all about the risk you're willing to take and minimizing risk, but certainly.
And stay away from grills.
Right. There are types of cooking that are more dangerous than others. So, another question,
Ross?
Yeah.
Greg again. That was a couple years ago. I went to this MRS over in Benton Harbor, and they wanted me to get a job at a restaurant, and I didn't care for the idea.
Yeah, that doesn't seem like all that great advice if you're working at as a cook in a restaurant. That
I wouldn't do
that
it.
person maybe
come up with a better.
I once had a patient when I was at the University of Michigan who had been a truck driver, was having seizures, and applied for disability, was evaluated by a pulmonologist who said he could still drive trucks. Fortunately, the guy was bright enough to ultimately see a neurologist, and we corrected that issue. But anyway, there is plenty of bad advice out there.
Right. Other questions?
Okay.
A few other people.
No, I'm going to sign off, but I just want to say thank you to everybody. It's been very informative.
Okay.
Yes, I want to say thank you too.
You're welcome.
I want to say thank you to everyone too.
It was great.
Yeah.
Okay.
Good opportunity.
We need to hear from Dr. Burdette more often.
Yes. Thanks a lot, Dr. Burdette. We really appreciate you.
Very, very informative.
Mm-hmm. Absolutely.
And to sign off.
Okay.
Thank you here also.
I'm going to sign off too now.
Yeah.
Thank you.
Bye.
Bye.
Thank you.
Bye.
Bye-bye.